Okay, let's review a little bit of the wrist and hand and kind of the points I feel like I've taken away from it. So we're gonna start with de Quervain's. They also do like carpal tunnel, but I feel like we know a lot of it, like Phelan's, reverse Phelan's, looking for excessive edema, that kind of stuff. If it's bilateral, you're looking up to the neck, that kind of stuff. So I feel like carpal tunnel is a little bit easier to identify typically. So we're gonna start with de Quervain's. So de Quervain's, you're having some problems with that extensor tendon, the extensor pollicis brevis, and the abductor pollicis longus. So the like classics test is Finkelstein's, so you're kind of stretching away, so you're bending that joint, seeing if that causes issues. But the one that has a better sensitivity, a sensitivity of 0.99, is actually the what cluster, so the wrist hyper abduction and abduction of thumb test. And so basically with the wrist hyperflex, the thumb abducted, and MCP, P and IP in full extension, resistance is applied against the examiner's finger, and we see if that reproduces symptoms. So basically you're going to see some pain in the anatomical snuff box region. You might see a decrease in grip or pinch strength. And I feel like those are the big things that are typically gone over when you're looking at de Quervain's. So now let's move into Smith's versus Colles fracture, which just kind of like cracks me up because it feels like they give you all this information about a Colles fracture and then like no information about a Smith's fracture. So I feel like it's probably going to be Colles fracture, right? Anyways, so the Colles fracture is if you have like a foosh, and so it's going to kind of break like up and outward, so the fracture would be kind of going like that direction. Sorry, that's really hard to see, but oh well. And you might have some median nerve issues because the median nerve is going like right through that distal kind of like radius ulna area. And the Smith's fracture would be going the opposite way, that's like inward. They call the Colles fracture the dinner fork, and the Smith's fracture the garden spade, based on the shapes, like the dinner fork going up and then the garden spade going the other direction. And I'm like, I don't get that, not gonna remember it, but it's there. And so yeah, they talk a lot about Colles fracture. It's the one that you're gonna have the median nerve issues. Overall, same goals: normalizing flexibility, joint mobility, strength, endurance, all the stuff that we normally do. So that is that. Next, we're looking at I'm never going to be able to say that right. This is why I'm not going to be a hand therapist. But oh well. So we're looking at that contracture of those last couple digits. If it's associated with diabetes, it's likely going to be digits 3 and 4. And if it's not diabetes, it's 4 and 5. The goal is to prevent further contracture. It's just kind of the overall vibe of that. Now we're looking at a boutonniere deformity, which is the rupture of the central tendons of the extensor hood. And this is going to be the closer one. So this can be from trauma, RA, degeneration. Basically, slips off there. And so you get the flexion going over that joint and extension over there. We're really looking at that extensor hood and thinking if it hits first, then in that boutonniere deformity, we're going to have flexion here and extension there. Versus a swan neck deformity, we're having an issue with subluxation of the lateral extensor tendons. And so we're not having that here. So we're having that flexion at the tip versus with the boutonniere deformity, having it at the proximal edge. So swan neck is going to be that same extensor tendon issue where it's kind of coming off, but it's at the tip or the distal, whereas boutonniere is going to be more proximal. So yeah, very similar stuff with trauma, RA, degeneration. You're going to use an x-ray to look at that. Mallet finger. So we're having an avulsion fracture, and so which is causing us that similar kind of flexion, but it's not the same as that swan neck deformity because we're not having that forced extension. So you would use an MRI because we're having like that avulsion fracture. Jersey finger, love the questions about Jersey finger, because they're like, a person's finger got stuck on the jersey of someone else's in like the other team, and you're like, yeah, it's Jersey finger. Basically it's forced hyperextension at the DIP with max finger flexion, and the sign that you see is inability to produce isolated flexion of the DIP, and this is an immediate referral to a surgeon. And then we have gamekeeper's thumb, which is something to do with skiing. How do I remember that? I don't know, but gamekeepers in skiing has stuck in there. It's a sprain or rupture of the ulnar collateral ligament, and it's typically immobilized for 6 weeks. So, general overview, review. Sometimes it's nice to hear someone talk about it. Basically, Colles and Smith's fracture again. Colles is Fouche, Smith exists. Fun. The Quervains, we're looking at that what test. We're looking at the inflammation of the extensor pollicus or pollicus brevis or abductor pollicus longus, and seeing if that resist movement is causing some problems, if we're having some swelling in that area, or something that is causing a little bit less space for those tendons to go through. Jersey finger. If they ask a question and they're like, they're playing sports, they got stuck on someone else's jersey, this is it. If there would be an immediate referral to a physician if they cannot produce isolated DIP flexion with the rest of the fingers flexed. If that finger is being extended with the rest of the finger flexed, no idea how I'd do that. Don't think I can because I don't have Jersey finger. Then, yeah, that's the test that you're looking for Jersey finger. Okay. Mallet finger, we're having that avulsion fracture. And so that is causing our distal phalanx to go into that flexed position. Swan neck deformity is kind of in line with that boutonniere. Both of them are looking at that extensor tendon, but one of them is looking at it more proximal, boutonniere. B becomes before S. I don't know, maybe that'll help, maybe it won't. And so we are having that flexion in that area where it kind of skips over, and then extension in the rest of it. Same idea as RA trauma, all of that good stuff. Then the Dupuytren's is the looking at that association with diabetes, that flexion contracture with the palmar fascia of the 4th and 5th digits of people without diabetes, and the 3rd and 4th digits if it's associated with diabetes. Gamekeeper's thumb, think skiing. Immobilized for 6 weeks after this happens. Yeah, that's a general overview. Okay.